Hello, welcome. Uh, if you feel comfortable with it, please enter your name and your organization in the chat box. We will get started right at the top of the hour. All right, it is noon. If you'll please put your name and your organization into the chat box so we can know who's been here with us today, and we will get started. First, thank you all so much for joining me today. My name is Tina Conyers. I am a quality improvement facilitator who primarily gets to work with Iowa nursing homes. I'm really excited to be able to present on this topic, and I appreciate you being here. The oral diseases afflicting older adults have been described as a silent epidemic. And for myself, having a decade as a swallowing disorders expert, I would agree with this. Before we end today, I hope you will all feel comfortable and confident to identify processes to prevent infections stemming from or exacerbated by oral health and hygiene, to screen individuals at high risk for oral infections, to apply tools and resources for processes and infection prevention strategies as they pertain to oral health, and to leave in action with a plan to implement a positive change in your facility's oral care processes. Oral health includes your teeth, lips, gums, palates, tongue, and oral mucosa, as well as the functions of eating and drinking, breathing, speaking. A September 2023 study found that for every 100 Medicare beneficiaries, 65 years of age and older, 27 have dental problems. And this is only accounting for people that still have teeth. This does not include those who are edentulous. Oral health is intrinsically linked with general health. Oral health used to be considered a mirror of or a window into general health, but continued research suggests that for many of their interactions, a two-way street is a much more accurate analogy. Nurses reported oral care as the third most missed element of nursing care, whereas patients identified oral care as the #1 most commonly missed aspect of nursing. Why is this important? Well, there are nutritional considerations. If our mouth is hurting, we will be less likely to eat a full meal. If we don't have any teeth and substantial oral weakness, how many of us here are going to be salivating over the pureed entrees for the day? Poor oral health is the most prevalent risk factor for malnutrition. There are social considerations too. If we neglect to brush our teeth in the morning, let alone for a few days, do we feel confident and comfortable having close conversations with people? Are we self-conscious about how we're smiling? Our resident population, they already struggle with social isolation. Poor dental health and oral cares have a psychological impact on us all. And mortality. Now, the number of teeth one has is associated with all-cause mortality. Oral inflammation is not sequestered to only the oral cavity. Poor dental hygiene impacts the morbidity of so many illnesses. Overall healthcare costs of people with diabetes lowers an average of 13% when they are treated for periodontal disease. There are also connections with pulmonary lung disease, rheumatoid arthritis, heart disease, and hypertension. The progression of many neurodegenerative diseases may be slowed through early identification and treatment of oral conditions and diseases. There have been many studies confirming the relationship between poor oral cares and increased pneumonia rates. Let's talk more about this. Pneumonia has consistently been a primary origin of infections that engender sepsis. Depending on the year, it's one of, if not the most common healthcare-associated infection. Pneumonia is a leading cause of death for the elderly. We can provide our residents a vaccine for viral pneumonia, but there is no vaccine for bacterial pneumonia, which is caused by aspiration. Most of the pneumonia cases in the frail elderly population are caused by aspiration pneumonia. About half of us here are aspirating on our saliva while we're dreaming, and so are far more of our residents. And no matter how much Hormel or Simply Thick probably wishes, we will never be able to significantly change the consistency of saliva, especially while we're sleeping. In the middle bullet point here, these were video fluoroscopic swallowing studies of people hospitalized with pneumonia and a healthy control group. What I found surprising is that about 1 in 5 healthy residents will be at risk for aspirating. Now, a quick caveat here, which is that this 20% measure is only for penetration, not aspiration, meaning that the material went down the wrong pipe, but it didn't go down past the vocal folds. However, it's still significant because a swallowing study is just a tiny snapshot of a person ingesting very small amounts with ideal upright body positioning and ideal intake rates. If there's a healthy resident reclining while eating and chugging juice at the end of a long meal, then the story can look very different. Does your facility already have protocols in place for meal positioning for those who are at a higher risk? Aspiration alone does not guarantee an infection, though, which is great because last Wednesday when you were drinking coffee and someone startled you and you coughed most of it out and you'll be fine. It depends on the pathogen or the consistency and amount of material aspirated and the immune system of the person. Typically, one needs 3 out of 3 specific circumstances to develop pneumonia. Here are some risk factors, but this list is far from exhaustive. Aspiration pneumonia is an opportunistic illness. It takes advantage of a body that is already compromised by illness, such as chronic lung or cardiac disease, diabetes, cancer, neurological disorders, renal failure, resulting in a less than ideal immune system. In pre-COVID times, in a 2018 data brief, the CDC reported on the number of nursing home residents that have at least one chronic condition. 86%. It's important to have processes built in for recognizing who is at higher risk, such as those with dry mouth, which increases the risk of tooth decay and is the side effect of hundreds of medications. For pneumonia to occur, one typically needs, first, an aspiration event, second, an underlying disease, disorder, or disability leading to a compromised immune system, and third, This one is the most modifiable risk factor. Here is an unfun fact. Aspirating just 1/10 of a milliliter of saliva can introduce 100 million bacterial pathogens from about 700 unique species into your lower respiratory system. How does your facility assess your residents for pneumonia risk? And what actions are you taking given the results of those assessments? If a facility does not have strong processes used consistently, then it has opportunities for improvement. Processes include written protocols and standard operating procedures, making sure that supplies and protocols are conveniently accessible and specific. Staff must be able to recognize dental and oral health concerns by sight or smell or touch. They need to recognize which approaches can mitigate resistive behaviors. And they need to recognize methods for adapting oral cares for persons with physical or cognitive impairments. All of this recognition can come through the initial oral assessment and the individualized care plan for each resident. Communication must be clear, consistent, and as convenient as possible. Communication to nursing aides about which products must be used, for what amount of time, about which behavioral interventions are beneficial, or what specific modifications are required. And then communication from nursing aides to nursing leadership about changes in status, about barriers, and about successes. We're all very, very fully aware that there are many barriers to having sufficient oral cares for all residents. There are just too many tasks that need to be done every day in nursing homes, let alone multiple times each day. So where can we find the time to give for oral cares? Where can we find the time to give for education and training for oral cares? And there's also been a lot of contradictory recommendations for oral cares, which makes a process less alluring to stick with, right? Later in this presentation, I will provide resources for the most current best practice guidelines and resources that give strategies to deal with barriers. We've seen in the research that education alone isn't getting the job done. So how can you set your facility up for substantial and sustainable success? I've put some general best practices on the left, although again, this list isn't exhaustive. It's recommended that staff have interactive, hands-on training by professionals. Many studies have recommended dental hygienist cleanings to be on a weekly basis, but other studies have shown significantly improved oral health with monthly visits, which of course is going to be way better than no professional cleanings at all. By providing oral care guidelines and hygiene aids, you'll be making it easier for your staff to be successful. It's important to assign someone to be the champion of the new oral care routine, someone who can oversee the program. Let's talk about dentures. Dentures can harbor dangerous pathogens. The study referenced here found that more than half were contaminated. Gaps in nursing homes can include a lack of standardized processes for the optimal, correct cleaning techniques and use of products. I've seen nursing aides cleaning dentures with a regular toothpaste which is just too abrasive, creates scratches that increase microbial growth. I've seen too many cases of reusing the soaking water for multiple nights, or finding eggs still in the mouth of a person who's about to go to supper. While we're talking about common missed areas, for dependent residents that do have teeth, please ensure all of your staff know to floss first, rinse second, brush third, and not to rinse the mouth after brushing. Right, because if you want the cavity protection, the fluoride needs to rest on the surface of the tooth. By rinsing, you aren't getting any benefit from that toothpaste. Here's a table of recommended cleaning methods for different types of plates. Let's talk about process actions. They can be categorized as weak, intermediate, and strong. Weak actions, well, this is all on your staff's shoulders to remember. So things like audits, new policies, providing only training and education. Intermediate actions, and with these, staff still need to remember, but the environment is set up for better success. It's easier to do the right thing. Examples would be decreasing workloads, reducing distractions, having checklists, having built-in redundancies. Strong actions, these will change or redesign the process itself. To be effective, interventions or corrective actions should target the elimination of your facility's specific, individualized root causes. This will offer long-term solutions to the problems. If you're wanting a refresher on root cause analysis, you can find a live webinar every month at Telegen, as well as an on-demand recording. In addition, any intervention must be achievable, objective, and measurable. Here are a few options for assessment tools. If you enjoy the assessment you're currently using, these could serve as a gap analysis tool as well. I'll share some resources for planning mitigation strategies. Mouth Care Without Battle is a program that uses adult learning techniques and has video demonstration of oral cares being given by actual caregivers to actual residents with physical or cognitive deficits. So rather than writing about the principles of it, it shows the real world application of skills and techniques. The citation link on this slide will take you to the CMS page, where you will be able to scroll down to the download section for this zip drive. This no-cost guide was developed specifically for nursing home teams to further reduce adverse events associated with infection. The head-to-toe infection prevention toolkit contains practical and pragmatic tools for person-centered care that help prevent and control infections such as pneumonia, but also UTIs and skin infections. This resource here is 144 pages of evidence-based best practices. Although a lot of those pages are just references and credits, it spells out step-by-step information for identifying risk factors. It provides assessment tools, oral care plans, toothbrushing techniques, denture care, tools and products for oral care, communication strategies, and threat reduction strategies. It also provides detailed descriptions of further resources. It's recommended to have a team dedicated for oral health and pneumonia prevention. An interdisciplinary approach will bring the right people to the table to examine this issue from all the necessary sides. Leadership support, it's imperative to a successful and sustainable positive change. The leadership team will need to prioritize time and resources for oral health, seeing it as an investment in time now that will result in greater gains of time back later. Ongoing training and education as needed must also be prioritized. It's vital for leadership to continue tracking data and monitoring the program, and especially acknowledging and incorporating feedback from the staff who are completing the cares. To improve sustainment of any oral cares program, I've said it before and I'll say it again, choose a person to be an oral care aide or champion. So someone that can provide support to other staff, someone that can ensure supplies are always readily available, and someone who can provide care for the residents that may be more resistant or require more time and attention. There's evidence that implementing these types of programs can make significant positive changes. HAPPEN, which is Hospital-Acquired Pneumonia Prevention by Engaging Nurses project, which the implementation guide for this program is the second link here at the bottom. It dramatically decreased rates of pneumonia in all of the tested sites. And in fact, in July of 2021, the initiative was implemented in every single VHA medical center in the nation as standard of care. Given what we know about the connection between our oral health and our general health, every minute spent flossing, every bottle of mouthwash, every dental hygienist visit is a solid investment, not only for our residents' quality of life, but also for the financial well-being of a facility. Here are our action items. Complete a gap analysis of your oral health program and processes. Include feedback from your staff doing the cares and any root causes you've determined from previous dental emergencies and pneumonia cases. Ensure that every person on your team is clear on their part in protecting your residents' oral health, and that all of your facility views oral cares as a means of infection prevention and control. Even small actions for independent residents that can ease the friction of the task, like bringing a loaded toothbrush and a kidney dish while they're watching The Price is Right. And these actions add up and make a difference. Make your processes standardized throughout the facility. We recommend starting small with changing just one part of your process. Whichever goal that you choose to implement, include each part of SMARTY. And it's that specific, measurable, achievable, relevant, time-bound, inclusive, equitable. And acknowledge the great work that's being done. Give specific praise to your team and to your residents. Celebrate every small success and then celebrate it again, because this is a big deal. Here are some resources that were not already linked in this presentation. This is a link to Telligent's secure portal. You can find all of our events, tools, resources, and data reports to support your work in healthcare quality improvement. Our online network also provides a place to share and learn about innovative practices. And as with everything at Telligent, this comes at no cost to you or your facility. This has been a lot of information in a short period of time. I wanted to save at least a few minutes at the end to ask what questions have popped up. What can I hope to answer?
Thus far, there's nothing in chat.
Okay, that either means I've done a stellar job or a really terrible one. Please feel free to come off mute too if you have a question about any of this.
Sudi and Sudi, I hope I'm pronouncing that right. In chat, put thank you for the information. No questions.
Oh, well, thank you. Please feel very welcome to contact us. You know, it's what we're here for. I've included my email at the bottom if you'd like to connect with me directly. And thank you. Thank you for being here. Thank you for the important work that you do every day. As a reminder, please fill out the post-event assessment once the session ends. It'll pop up in your browser. You will be helping this quality improvement person improve their quality. So thank you for participating in the training. And I hope you all have a wonderful rest of the day.